Assalamu alaikum. Today we will dig a bit deeper into cutaneous vasculitis and continue with immune complex mediated small vessel vasculitis. And in this category, we have 4 diseases, namely antiglomerular basement membrane disease, cryoglobulinic vasculitis, hypocomplementimic urticarial vasculitis, and finally IgA vasculitis. In immune complex vasculitis, immunoglobulins or complement are deposited at the vessel wall. All 4 types of immune complex small vessel vasculitis are considered as systemic vasculitis with antiglomerular basement membrane disease showing no cutaneous affection, while the rest may have a cutaneous component or even a skin-limited form with subtle systemic affection. The cutaneous vasculitis in all of them is a leukocytoclastic type of vasculitis with immunoglobulins or complement deposition around small vessels, as can be detected by direct immunofluorescence. Starting with cryoglobulinic vasculitis, this is a systemic inflammation due to excess cryoglobulins, which are immunoglobulins that precipitate at low temperature, resulting in vasculitis and blood hyperviscosity, leading to ischemia and tissue damage with predilection of the skin, kidney, and peripheral nervous system. There are 3 types of cryoglobulinic vasculitis. Type 1 is formed of monoclonal immunoglobulins, mainly immunoglobulin M. In type 2, we have monoclonal immunoglobulin M plus polyclonal immunoglobulins. In type 3, we have polyclonal immunoglobulin M plus polyclonal immunoglobulin G. The IgM fraction in cryoglobulinic vasculitis has a rheumatoid factor activity, so it's not surprising to have a positive rheumatoid factor in more than 70% of patients with mixed cryoglobulinemia. But it can be associated with autoimmune disease, infections, and neoplastic disorders. Hepatitis C virus, Epstein-Barr virus, and systemic lupus erythematosus are the most common associations with type 2 and 3 cryoglobulinic vasculitis, while monoclonal gammopathy and hematologic malignancies are most common with type 1. Systemically, these patients may show signs of associated disease, for example, hepatitis or presence of arthralgia and asthenia, GIT, or even peripheral neuropathy. Dermatologic lesions include purpura in more than 50% of patients. Other commonly seen lesions include livedoid vasculitis, ulcers, and even gangrene, urticaria, and drainage phenomena. Historically, cryoglobulinic vasculitis was characterized by the triad of purpura, asthenia, and arthralgia. Cryoglobulinic vasculitis is screened by testing for presence of cryoglobulin in serum, then characterizing their type by electrophoresis. Further investigations are always required to identify cryoglobulinic vasculitis associations or causes. Next, we have hypocomplementimic urticarial vasculitis, or anti-C1q vasculitis, which is another type of immune complex small vessel vasculitis that presents primarily with urticarial lesions in the settings of a connective tissue disease. The urticarial lesions in this disease are highly atypical, with prolonged duration, fixed sites, and residual hyperpigmentation in association with minimal itching. Angioedema, purpura, and livedoid lesions are also quite common. Hypocomplementimic urticarial vasculitis is often associated with systemic manifestations including arthralgia, pulmonary, renal, or even GIT symptoms. The disease starts with a trigger that is largely unknown, but could be an infection, drug, or an autoimmune disease, or even a malignancy. This trigger induces the production of IgM against C1q. This immunoglobulin binds to C1q and forms an immune complex that is deposited in the vessel wall and activates the classical complement pathway with degranulation of mast cells and recruitment of neutrophils and eosinophils. These cells injure the endothelium, leading to a leukocytoclastic vasculitis picture. In hypocomplementimic urticarial vasculitis, there is a persistent activation consumption of the classical complement pathway, leading to severe hypocomplementemia. On the other hand, in normocomplementimic urticarial vasculitis, there is no antibodies specifically targeting the C1q portion of the complement, but rather an antigen-antibody immune complex activation of the classical complement pathway with milder activation and consumption, predominant skin lesions, and rare systemic manifestations in contrast to the hypocomplementimic type. The diagnosis of hypocomplementimic urticarial vasculitis must include 3 of the major criteria and at least 2 of the minor criteria. The major criteria include urticaria, which is persistent more than 6 months, laboratory evidence of hypocomplementemia, and detection of anti-C1q autoantibodies. The minor criteria may include leukocytoclastic vasculitis on skin biopsy, arthritis, uveitis, glomerulonephritis, or recurrent abdominal pain. Our final disease in this category of immune complex small vessel vasculitis is the IgA vasculitis or Henoch-Schindler. This is the most frequent type of vasculitis among children, and its exact cause is unknown, though it is possibly related to a preceding infection in the setting of certain genetic and environmental factors. The major criterion for diagnosis of IgA vasculitis is the presence of purpuric lesions on the lower limbs of a child, commonly with thrombocytopenia. At least one additional criteria should be present for the diagnosis of Henoch-Schindler. These additional criteria include arthritis, abdominal pain, renal involvement, skin biopsy showing leukocytoclastic vasculitis, and direct immunofluorescence with IgA dominant deposits on the vessel wall.